So most of the people who come across with the criminal justice system in Pakistan, where they suffer because of unrecognized psychiatric morbidity, might not even suffer from mental illness per se, but might have learning disability, which is also called Zehni Mazuri, or was previously known as mental retardation. And basically this means that they have a developmental impairment or there has been an injury to the brain, and as a result their intellectual capacities are compromised, and maybe their ability to comprehend or make judgments is lesser than an average person. These people are extremely vulnerable, and they can easily, they are not hardcore criminal minds, but they are so susceptible that they can reoffend and become regulars in the system. For learning disability, there might not be medical treatments, but there is effective interventions for rehabilitation. For substance use disorders, which are highly prevalent in the prison system, the prevention is extremely important, and we know that there are scientific interventions which are cost effective, which can be implemented. For mental illnesses, largely they are treatable. So 99% of mental illnesses can be effectively treated with drugs which are not very expensive. And for people who have personality disorders and they commit crimes, we need long-term secure facilities. The present prison system might not be the right place for them to live on for years. And you can also see that there's an overlap. So somebody entering the prison system with learning disability could then end up develop a mental illness or fall susceptible to the use of substances that are accessible there. So the reasons for the high rates of people with mental disorders in the prisons are, number one, because there are increased chances for these people to be arrested because of the alleged offences, and therefore there is a high risk of arrest. Number two, in the community there are inadequate services. So people who are in the community, they do not have access to effective services anyway. Number three, at the point of entry into the prison system, there is no mechanism to identify that people with mental disorders are being arrested or imprisoned. And number four, during the process, the justice process court proceedings, there is inefficient psychiatric assessments. So what are the objectives of providing mental health care in detention facilities? The first objective is that the prisons or the structural challenges or the challenges of the functions that Reto was highlighting, the adverse psychosocial factors in the prisons, they could be addressed, or some of them could be addressed, so as to prevent mental disorders. The prevention of mental disorders in detention facilities is very important. The second is to ensure treatment in these facilities. These are cost-effective treatments, and it is their basic right of the people in the detention facilities to have access to treatments. Number three, to assess towards when a detainee's mental capacity is in question. And number four, to protect. So this is while they are in prison, this is when they are going through the justice system, but the broader objective of providing mental health care is at the interface of your criminal justice system and the community. So the broader objective is to protect these people who are vulnerable to mental disorders from becoming victims or violators of law or reoffending. So the mental health care needs in the detention facilities can be explained at different levels, and we have already discussed that the challenges in the prison environment, both in terms of structure and how the prisons function, there are adverse factors, and there is a very close association between the adversity of the prison system and prevalence of psychiatric morbidity. In addition, there are high-risk factors like violence, harassment, bullying, substance abuse, for which protocols for incidents of violence or policies about access to drugs of addiction in the prison environment becomes very important. Common mental disorders are extremely important. These common mental disorders are prevalent to the extent that rough estimates, according to rough estimates, about 90% of people who are detained, and like Reto said, more than 60% are still going through the trial, have not been convicted. They suffer from common mental disorders, including psychotic disorders, depressive disorders. And the point here is that these common mental disorders can be very easily treated by non-specialists. We do not have enough psychiatric specialists in the country that we could offer 80,000 or 70,000 people this psychiatric care. This has to be provided through identification by the security staff at the prison, and the treatment has to be dispensed by the healthcare staff, the medical officers at the prison. The irony is that these doctors or these healthcare staff are not trained to identify or treat common mental disorders. The WHO clearly states that these mental disorders are to be treated in the community or in the prison systems by health professionals and not by mental health professionals. In addition to providing treatment for common mental disorders, the security staff or the healthcare staff at the prison needs to be trained so that they can identify people who are suffering from severe mental disorders, and then these could be assessed and treatment offered within the prison system by a visiting psychiatrist. And very few people suffering from severe mental disorders would need to be shifted or transferred to a specialist facility. So mental health care broadly can be divided into correctional psychiatry and forensic psychiatry. Correctional psychiatry is based on a therapeutic medical model which is dispensed by a psychiatrist who is also a physician in a doctor-patient relationship with the basic objective that he's working to prevent mental disorders, to treat people who already have become unwell, and to help rehabilitate the ill people in the detention facilities. And the forensic psychiatry, on the other hand, is not based on a therapeutic model. Forensic psychiatry means that these are independent assessments. This is very important. These are independent assessments which might not have any part in the treatment, and the whole objective is to assist the courts so that they can focus and assess the capacity of the person. They are not too varied with the diagnosis of the person. So if I go back to make a point about the first slide when I was showing you different kinds of mental disorders, even if somebody has schizophrenia, or even if we consider the diagnosis of schizophrenia, that does not necessarily mean that people with schizophrenia will not have the capacity to plead or for sentencing. So basically what I am saying is that the courts need help, expert help in assessing individual cases on the merits of whether this person is able to understand what is happening to him or not. And I think Sarah is going to say a bit more about that. So the gaps in existing system, I'm trying to take you through a checklist of what should happen in a prison and what is not happening in our prison system. So the first point, like I have said, is that it is extremely important that we develop a mechanism, however basic the screening is, but we need to start identifying people who are at risk or are already unwell as they enter the prison system. Extremely important. The second is that the essential medication, I have personally provided services to Adiala jail for years, and I know that I would go once a month and I would prescribe somebody a basic antipsychotic, which is like maybe 5-10 rupees tablets, and next month I will go and I find out that this person has not received the treatment because the drugs were not available. So basic drugs are missing. The health records are so poorly maintained that you can go back and you can't even have access to the vital signs on people who are severely unwell. And in the case of Khizr Riaz, we know that he stopped eating and he became so anemic and he died of medical complications. And none of this, all of this could have been prevented, but it wasn't prevented. Trained medical staff. And for the health records, I also want to say that the observations by the jail or the prison staff on the behavior of the patient, on how he interacts, or his sleeping pattern, or his eating pattern, it becomes extremely important. So psychiatrist coming in for 10 minutes assessment would value that greatly if somebody could give him an accurate account of this person has been during the whole month. Trained medical staff, I've already said enough that this is very important. We need to focus, and this is probably where the NAPA comes into action, or should come into action, because we have well-developed modules by the WHO to train non-specialists in identifying and treating mental disorders. At most, it's a 7-day treatment, 7-day training session with 6 months of hands-on supervision. And an ordinary person, we've done these trainings in Parachanar, we've done these trainings in Banu, we've done these trainings through concerts for rural centers in all provinces in Pakistan, and we have trained even a lady health worker sitting in Swabi or in Balochistan, Gwadar, to recognize depression. We've done this, and this is possible. Continuity of care is more important than for a person who suffers from diabetes or hypertension. We all can understand that monitoring mental state examinations and understanding that person who's unwell is more important in psychiatric care than in other medical care. Referral links, effective referral links with specialist services are needed. And the process for transfer to psychiatric wards is extremely difficult because most wards do not have secure facilities. I have never forgotten that patient who was transferred to one of the public hospitals where I worked, and he escaped from there. So in the justice system, likewise, there is a checklist, and important points here. The first point is that all of you would look up to psychiatrists as experts for producing these forensic reports and telling us whether this person has the capacity or not. But the irony is that these specialists are not well trained. These specialists are not well equipped to produce good, accurate reports for us. So the training of psychiatrists, it needs immediate attention. The other point is that these psychiatrists are employed by the provincial government. They are not just employed by the provincial government, but they have no legal or administrative protection, and therefore they are highly vulnerable. They are more worried about securing themselves and the consequence of what they might write. So it's about protecting themselves rather than being accurate and objective in their reports. The courts very often do not even state the reason why they are sending a prisoner for psychiatric assessment, and that changes the whole paradigm of doing that assessment. So if judges were more aware that how to make these requests and what important information to give, these reports will become more meaningful. After there is a request by a court for psychiatric assessment, the process that follows in the hospitals is far from satisfactory. The hospital administration constitute these boards. Some of the board members are not even trained mental health professionals. They could be neurologists, they could be medical administrators. In other cases, a group of 2 or 3 psychiatrists will get together. And like I said, these psychiatrists are insecure in their positions, they are not independent, they have a dual line of reporting. So what they end up doing is put up a quick report together which will not cause any dissent and no problems for the system. So these reports are geared towards not producing problems for the system. Most of the time these reports are incomplete, inaccurate, and not helpful. Because when a report that a person has schizophrenia or a person has depressive disorder lands on the table of a judge, he is unable to interpret that report in the context of his case. He doesn't know how to make the best use of that report. And this unfortunately violates or may violate the rights of the person who might not have the capacity to go through that case. So this is my last slide, and I'd like to share what has been happening with the mental health law in the country. There was Lunacy Act 1912, which was replaced by the Mental Health Ordinance 2001. After the 18th Amendment, the provinces passed, or they were expected to pass their own legislations. So the province of Sindh, Punjab and KP have passed their mental health acts. These are based on the same draft of the original Mental Health Ordinance 2001. It has been passed, and Sindh and Punjab have also notified their mental health authorities, but nothing much has been done since. This process has been going on for the last 5 years. Considering the loss of time and the pace of what is not happening, there is not much expectation that there will be immediate action, but we need to understand that the mental health legislation to be implemented in true spirit in the provinces is extremely important. And like you can see here, the mental health ordinance clearly said that the inspection of mentally disordered prisons at regular intervals by the IG prisons or his team. And therefore, once these people were identified and then reviewed 6 months down the line, there is a possibility that some kind of mental health care, however rudimentary, should initiate. Thank you.